Okay, great. I'm David Gonda. I'm one of the pediatric neurosurgeons here at Rady Children's. Just to introduce myself. My only disclosure is that this is my first webinar experience. So if there are any problems, please let me know. Any questions, feel free to interrupt.
And I'm Shifteh SATTAR. I'm the epileptologist at Rady Children's. I'm just gonna kind of be here to give my version of the experience with the ROSA.
In order to kind of talk about the ROSA, I think it's easiest just to show a few example cases that we've done. And so we've put together a couple with SEEG, the stereoencephalography, where we've used the ROSA for the planning of our procedures and then also the procedure itself in some cases. We've also looked at a couple other uses that we found with the ROSA since we've obtained it here. The first case, this is a 17-year-old who came to us with intractable epilepsy. She had actually had a right temporal lobectomy 2 times. The first one 8 years previous, and then again 1 year after. Or 1 year after, yeah, a few years after she had a redo temporal lobectomy on the same side, just kind of expanding the margins after her seizures recurred. Again, now her seizures have recurred. They're happening several times per week. She's highly functional. She's graduated high school recently. She has the goal to go to the local community college and begin taking classes, but is limited in that she's still unable to drive because of the frequency of her seizures. So the family's very motivated in order to treat these. Surface EEG electrodes still seem to show kind of a frontotemporal source of the
just to add to that, the challenge when we were reviewing her scalp electrode was that basically with the 2 resections, it appeared some of the seizures were coming from the left instead of the right. So given the fact that she has failed 2 surgeries, we thought that maybe she had bilateral disease. And it would be difficult to identify that. So we thought that the SEEG would be the best way to do this, especially since we needed to access the posterior portion of the hippocampus on that right side.
You can see in the middle picture here, there was some residual hippocampus left behind. One of the problems with surface electrodes here too is that if that part of the hippocampus is where the seizure is originating, by the time it gets to the surface, it may have also already gone to the other side of the brain because it's missing a lot of the temporal lobe that was resected there that the electrodes would have otherwise detected. Her seizure semiology. You want to talk about this?
Yeah. So she has I call it nonsensical speech, but she speaks Spanish and say my arm's broken, I'm going out, and it's just not making sense. She's just woken up from sleep, and the mom's like, "What are you doing?" "I'm brooming," and sometimes she's just dropping objects that doesn't make sense in locations that weren't. So basically, dyscognitive seizures with behavior arrest, and they were disrupting her lifestyle such that mom would be with her at all times. She would never leave her alone.
So here are some of her video EEG results.
Well, this is an interictal EEG that shows spikes. I think you can. Is there an arrow? No. So there's some spikes over that right frontal area, and basically you can see there isn't that much activity on this interictal video EEG, and then on the ictal you can see this rhythmical delta over that right frontal area, but sometimes it would also be very vague over the left. It seemed more prominent over the left. And then this is her EEG seizure onset, that it keeps going non-specific rhythmical theta. So it was very hard for us to assess where it really truly was coming. We did a MEG that also was able to show us the cluster of spike activity over that right area. But again, this is just accumulative data, and so we couldn't ignore the fact that some of the seizures were looked bitemporal or bifrontotemporal.
So at this point, we knew we needed some invasive monitoring. Traditionally at our institution, we've been doing grids. The problem with, or Foramen O'Malley electrodes also. The problem with grids in these instances where the question is whether or not these seizures are coming from a more mesial location. And it's also hard to do bilateral grids when we're looking at the when we're considering the left side is also focus of seizure origin. The natural and the Foramen O'Malley electrodes. The problem with that too is that Foramen O'Malley electrode on the right side, where the temporal lobectomy had already been performed, we couldn't be sure that our electrode would even contact brain reliably in that placement. So again, so this was an instance where we were able to consider doing stereotactic EEG with placement of a series of depth electrodes through the scalp. Although it's more invasive in the sense that you're entering the brain, it's also much less invasive overall in that you don't have to do an entire craniotomy. It's much more tolerable for the patients and lower risks when it can in terms of infection and CSF leaks. The ROSA, so a year ago in my fellowship, before we had, or during my fellowship before we had the ROSA, we were using a head frame to do this, just a Lexel or CRW head frame. For each electrode, we'd have to take the head frame off, dial in a series of coordinates, check those coordinates, put it back on, which ended up taking about 45 minutes to an hour per electrode to place. With the ROSA, we have a mechanized stereotaxy, which enables us to be able to place these electrodes very rapidly. So we can place a dozen, 10 or 12 electrodes in a matter of a couple of hours, as opposed to it being a 10 or 12-hour case. This is just kind of a picture of the ROSA arm here. You can see how it holds the. Here it's just holding. It looks like a biopsy needle is what's actually holding, but it's able to guide where we go. We use that. We pass a drill bit through the instrument holder. We're able to then replace the drill bit with electrode and pass the electrodes directly in the brain. So.
And David, can I ask you, can you just comment on the drill bit, accuracy for the neurosurgeon? Is it hard for them to identify that, how to drill, so it's accurate?
Well, the ROSA arm directs us exactly where to go. And when you pass a drill bit through the bushing on the guide, it'll set right down on the skull. The ROSA will then tell us how thick the skull is, and we use a little stop on the drill bit so that we can know exactly how far we need to drill. The other advantage to the ROSA in comparison to a traditional head frame is that the traditional CRW or Lexel head frame, your bushing that guides the drill, because it's done in the same way, may be up to 10 centimeters away from the surface of the skull. And that 10 centimeters leaves a lot of room for the drill bit to bend one way or the other, especially when the skull is not directly perpendicular to the skull bit. It may have some angle to it and may cause the drill bit to walk down at just 1 or 2 degrees of walking down the skull or bending of that drill bit can really change the trajectory of your electrode. With the ROSA, it's very convenient because once the robot has identified the trajectory, you can move that bushing back and forth along the trajectory and get your drill bit and the bushing itself is very close to the skull. So there's no room for the drill bit to bend or sway at all, and even coming in the skull at an angle, it won't. The chance of it walking is minimal. So for this particular patient, we planned out. This is right here is a screenshot from the ROSA planning software where we were able to plan out each of our trajectories. We planned out 10 different trajectories targeting areas from the right residual hippocampal area. We also put one in the left amygdala, the left-sided hippocampus. We put some in the superior, because if you remember back on the MEG, it looked like along the Sylvian fissure, the superior temporal gyrus, and then the margin of the resection cavity may also have been active, so we were able to place electrodes in there. We also put a couple up into the frontal lobe to make sure that there was not a frontal origin that had been causing the seizures.
Yeah, I think our goal was that this we were trying to make this her last surgery, and hopefully the most successful. And if you guys look at the image of the face with the electrodes, if you can see that some of them, the way we arranged or set up our electrodes, they look a little bit, what is the word? The trajectories are a little bit off, and they're a bit angled, and they're not very parallel to each other. One thing we learned from this experience is sometimes when I was trying to look at exactly like where the electrodes were on like CAT scan when we co-registered it and reviewing it for the EEG, it seemed a little bit challenging. So we've actually are trying to make it more of an orthogonal trajectory and very parallel to each other, so they're not kind of passing each other by millimeters and giving artifact and making it difficult to see which electrode is showing the activity.
Yeah, it's not enough just to simply place electrodes where we think there's activity. We need to be able to read them afterwards and know where they are, and that's what Shifteh is talking about. So the Cleveland Clinic group and that has kind of adopted the Talaroc method for this, and where they place all their depth electrodes orthogonal or parallel to each other and kind of orthogonal to the sagittal plane. Mm-hmm. And we found that in kind of adjusting our methods to do that, it's become much easier for the neurologist to be able to read the EEG results, and so that we can then map our surgeries. For this particular patient, our methods worked well enough here. It was hard because we were missing a temporal lobe, and generally you want your electrodes to pass through tissue as much as possible, as opposed to entering in through a large CSF space where there's room for the sag on the electrode and diversion from your planned trajectory. So with her, we placed 10 electrodes, 8 on the right side and then 2 on the left. This is kind of a post-op CT scan showing a handful of the electrodes in place. And here.
Yeah, so this is the basically a seizure from the SEEG electrodes, and I've just alphabetized them. Anything A to F was on the right side. A prime, B prime were on the left. And I don't have a mouse to kind of guide you, but if you can look at the very top where I put A, right hippocampus, you can see this fast frequency activity at A1, 2, and 3, the very top. Now, the bottom picture is about 50 seconds later, where you can see the activity is kind of continuing over the top, over the right hippocampus. And then later, at the very bottom of that, you can see that a little bit of a run of theta is coming, and that's the left hippocampus. So basically 50 seconds later. The activity you're seeing in the very middle portion of the bottom picture is the right middle temporal gyrus. So basically we were able to identify that the seizure onset is clearly coming from that posterior right hippocampus, and then over time, it would go to the left hippocampus.
What was very helpful to me as a surgeon was I knew that the superior temporal gyrus, the middle temporal gyrus, and the lateral portions of it up in the Sylvian fissure, frontal lobe, were all not involved. If we were to have to go back in here and do another craniotomy blindly, it would have just been a matter of extending our resection backwards and taking all that tissue, whether it was functional or not. And being able to identify that it was mostly this residual hippocampal region, but not only that, but also the fusiform gyrus just lateral to it, where all the residual seizure focus was. We're able to target our epilepsy procedure. Now, just to next, we'll talk a little bit quickly about how we did the procedure too. I think in Seattle, Dr. Ojerman is using visual aids, I've heard. So you may be somewhat familiar with this, but instead of the other advantage, is that correct?
Is that correct? Yes, it is.
Okay. So
yeah, for the last 2 years.
Yeah. So you guys are familiar with this, and these MR guided thermal ablations are really nice, especially when used in combination with SEEG, because frequently you can just back out the electrode and then replace it with the laser catheter itself. In this circumstance, in this particular case, we didn't do that because we wanted to put the laser catheter along the fusiform gyrus and along the posterior hippocampal gyrus to be able to ablate that. But I won't go too much into the visual laser catheter since you guys are familiar with it. But it is a minimally invasive way. It works really well for epilepsy. It's only a 1.6 diameter fiber. There's a 3.2 millimeter securing bolt that holds it. These laser catheters can be placed again with a Lexel or CRW head frame in the old-fashioned method, but again we use ROSA now for almost all of our stereotaxy when it comes to doing things like this. So we use the ROSA for placing this. The ROSA is you get your bang for your buck when using this robot when you're doing multiple trajectories, such as with SEEG, or in this case when we were actually doing 2 trajectories, we were able to do this very quickly with the robot. We weren't having to take the frame on and off and do multiple things again. So both of these trajectories, which you can see here, we did 2. We did one along the hippocampus. Trajectory 1, you can see mesially there, extending all the way to the end of the residual hippocampus. And then we did one pretty much parallel to that, tracking along the fusiform gyrus, which you can see labeled as trajectory number 2. Patient was then transferred from the operating room over to the MRI suite, and the electrodes were removed at the same time. We brought her into the MRI suite, and you can see the results of our ablation here.
And the electrodes take like 10 to 15 minutes to remove, very simply, right?
Yeah, the electrodes come out very quickly. It's just a matter of removing the bolt and stitching the hole in the scalp, which is about 3 millimeters in length.
And
so
it's under local anesthesia.
Yeah. Well, we put them asleep when we take out the electrodes. You could, generally you put them asleep when you take out the electrodes. We put them in an absorbable stitch, and then they don't have to come out and have anything picked out of their hair later on. You can see, again, our ablations of the mesial temporal lobe. It wasn't enough just to get the hippocampus. We did the fusiform gyrus too. Post-operative course, patient, we monitor for about 24 hours in the pediatric ICU. This was just out of our concern for post-operative edema. With a single trajectory doing mesial temporal ablations, the incidence of edema post-operatively is pretty low. Once we do more than one, we get a little bit concerned about it and just want to make sure that there's no problem. So we put her on a 1-week taper of Decadron.
Well, and in this case, she had room for swelling.
In this case, she actually had room for swelling too.
Yeah.
So even doing this was out of an abundance of caution. But she felt great immediately after the surgery. The probes were removed in the MRI suite. So she wakes up. She just has a couple stitches, a stitch at each of the entry sites in the back of her head. She has no headache. She had no pain. She felt fantastic. There was no new deficits, and she was able to go home the next day.
And I just wanted to add something. I don't know how you guys co-register your images, like post-implantation. For me, I came from Miami Children's, so we would use the Amide software and the Mevis Lab software to co-register the pre-op MRI with the post-op CT, and then basically create the electrodes and then see where they are. With the ROSA software, I can tell you it's made my life so much easier because all we do is put the post-op CT with the electrodes on the MRI that already had the planned electrodes that we had already pre-planned, and then we can also see that how much error is by the surgeon in placement, which is very little. And it just made my life so much easier to identify exactly where the electrodes are and what number is active and what number is not. And so I have not been really using the Amide or the Mevis Lab to fuse these images anymore.
So fortunately...
we use a software that I brought from Yale called Bioimage Suite, and and we co-register all the other images as well as the post-op CTs as well. So we've been using that software for the last 6 or 7 years here. So.
Yeah, so it made my life so much easier for this one at least.
how do you, I guess the question is, do you have the ability with the proprietary software through ROSA to co-register all of that other stuff that is in, it's not a DICOM format, I don't know what format.
Nifty.
Now, Mike, I think you said that's in the works, right? Mr. Pratt, is he there?
Oh, yes, I am. So that is correct. What I'd like to do is let's hold a couple of technical questions to the very end, and then we'll get to the rest of the presentation.
Okay, go ahead.
Okay. All right, we'll go through, I guess, we have a couple more cases here we'll run through, and then we can go over the questions. So this was just a great case. This is a girl who was being threatened with a third craniotomy. We're able to do it entirely minimally invasively. She didn't have to go through all the recovery associated with it, and has had a fantastic outcome. And, has been seizure-free at 5 months follow-up thus far, when she was having several seizures per week. And so we're very excited about that.
Just a question. So you talked about taking the stitches, not needing to pick things out of her hair. So that whole procedure was done without shaving the head, correct?
Correct. We did not. She has long, thick
hair, lots of them.
Long, thick, lots of dark hair, and we didn't shave a single spot. So all her hair is
very exciting.
Yeah, all the girls were very happy. Yes.
We just recently did a laser ablation on an adult patient who came over for that same reason. She did not want to have a craniotomy purely for cosmetic issues, and we didn't do SEEG on her, but we did use a robot, and she's was able to go home the next day after this ablation, and she
and one thing to mention, after an open cranie, these kids, they have lots of swelling, they're in pain. There's almost no pain. I think that post-op day 0, they require maybe Tylenol with, a Lortab, Tylenol with codeine, and then the next day they're just on Tylenol, and they're just up and sitting and talking and interacting without any pain and discomfort.